I'm excited to welcome everyone to this session 16, which is opioid, excuse me, and behavioral health success stories, community partnerships, and building a system of care at all levels. So I think we'll start our session. I'm really excited to introduce our speakers today. They're all well known to me. First, we have Michael Dulitz. Michael has been the Opioid Response Project Coordinator at Grand Forks Public Health since 2017. In this position, he oversees the implementation of community opioid addiction efforts and oversees the department's syringe service program. Michael has a Master's of Public Health degree from UND, a Bachelor of Sociology from Augustana College, and has been a paramedic for 10 years. Michael lives in Grand Forks with his wife, Laura, and their dog, Millie. Also today, we have two community members that will be reflecting on some of their thoughts on this topic as well, and they are both with Agassi Associates here in Grand Forks. Dr. Rebecca Green is a licensed clinical psychologist. Dr. Green graduated from the University of North Dakota with a PhD in clinical psychology. She's licensed as a clinical psychologist and has practiced in the state of North Dakota for 25 years. She's a member of the North Dakota Psychological Association and the American Psychological Association. Dr. Green's practice focuses primarily on providing individual psychotherapy with adults, adolescents, and children. She's experienced in conducting psychological evaluations and consultations. Areas of expertise for Dr. Green include the treatment of depression, abuse issues, grief and loss issues, anxiety, and women's issues. Also joining us this morning is Dr. Heidi Jensen. Dr. Jensen graduated from the University of North Dakota with a PhD in clinical psychology. She's licensed as a clinical psychologist and has practiced in the state of North Dakota for 20 plus years. Dr. Jensen is a member of the North Dakota Psychological Association. Her practice focuses primarily on providing individual psychotherapy for children, adolescents, and adults. She's experienced in conducting emotional and cognitive psychological evaluations. Areas of expertise for Dr. Jensen include the treatment of depression, anxiety, and ADHD. Dr. Jensen also is trained to address parenting issues, marital issues, and change of life issues. Before we begin, I also want to mention that we do have a disclosure that our presenters have indicated that this presentation will not include any discussion of commercial products or services and will not include any discussion of off-label and/or investigational uses of any product or services and will not include trade names. This is a requirement of the Dakota Conference for CME Education. And so at this time, I'd like to turn it over to our presenters. And Michael, I believe you will be able to share your presentation.
Thank you, Debbie, for the introduction. So as she mentioned, I'm Michael Dulitz. I'm the Opioid Response Project Coordinator with Grand Forks Public Health, and I put together this presentation. The time frame between applying to present and the actual presentation, of a few months in COVID time is equivalent to a few years, it seems like. And so I did take a little bit of I took a little bit of artistic judgment on how we wanted to use the time today, and I think we'll provide some really good updates on some of the good things that have happened post-COVID in the state of North Dakota related to behavioral health. So we're going to talk about three topics. First, we're going to talk about addiction care and some of the work that's been going on in Grand Forks with Grand Forks Public Health and Spectra Health on kind of integrating together our syringe service program and harm reduction programs into Spectra Health's primary care and integrated care infrastructure. Then we're going to talk about the North Dakota COVID Connect program, which would be of particular interest to individuals in rural areas and across the state, which is a program that is facilitated by Agassi Associates. And then we're going to do a little guided Q&A with Agassi regarding behavioral health care in a pandemic. And then finally, we'll open to questions at the end. The slides that you'll see today are relatively limited, again, due to the short time frame with putting together this presentation. We didn't want to focus heavily on the slides and have you not be able to actually see them. So a little bit of a touch base on harm reduction and primary care services. Grand Forks Public Health put together a syringe service program in 2019 that opened in the fall of 2019 as part of our opioid response efforts in the community. Our syringe service program was the kind of final major program that we're looking to put together. Our opioid response efforts have brought into the community Agassi Associates, who became an SUD voucher provider and provided services at the Grand Forks County Correctional Center. We were able to bring Spectra Health in to provide medication-assisted treatment services for people with opioid use disorder. We were able to bring in 2 other peer support organizations, one the F5 Project and 2 the Face It Together, that are able to provide services through the North Dakota Free Through Recovery Program and now the Community Connect program. So the final program that we put together was the harm reduction program, or the syringe service program, that does provide syringes and clean injecting equipment to people who use drugs in the Grand Forks area, and we serve people regardless of residency. We were originally located in the Grand Forks County Office building, but as the common theme in this presentation will be, COVID changed things a lot. We ended up moving overnight from providing services in the Grand Forks County Office building through special authorization from the North Dakota Department of Services on a mobile basis between March 2020 and January 2021. After January 2021, we moved our program into the Spectra Health building in Grand Forks, which has turned out to be a wonderful collaboration. So Spectra Health provides us a location for our syringe service program to be, but that's a small part of what they do. Spectra Health is a federally qualified health center located in Grand Forks. They provide medication-assisted treatment services to approximately 140 individuals in the Grand Forks area. They started with providing medication-assisted treatment services, and they've been able to integrate that into their whole primary care and integrated care spectrum. So located at Spectra Health, you can not only get your medication-assisted treatment services, but clients are able to get their routine primary care services. They're able to visit with behavioral health providers, and recently we've been able to add in a specific social worker to work with clients with addiction-related needs, particularly getting them connected to insurance services, getting them connected to getting them connected to housing and other services needed to help support somebody in recovery. It's hard to be in recovery and be homeless at the same time, or have other unmet needs. Another addition at Spectra Health, which has been integral to expanding out our addiction care services, has been the addition of an on-site addiction counselor. Spectra Health added an addiction counselor in 2020, and that individual works with all medication-assisted treatment clients, but also works with clients with other addiction-related needs, including individuals who have unmet assessment requirements, are looking for treatment for addiction related to other substances, are looking to get connected to other programming so they can do the assessment, connect them to other programming, or various court-related needs. And then finally, we moved our syringe service program into the same building as Spectra Health. So we operate on the first floor, and we have a good working relationship with all of the other floors at Spectra Health. So their social work program, their behavioral health providers, their primary care, and their addiction care providers. It seems weird to provide a certain service program in the same location as a primary care clinic, but we've quickly realized that we are serving us in many ways, shapes, and forms the same populations. So we have people that are referred back and forth for services. We have a wonderful working relationship with our social worker and addiction counselor who are focused with our programs, and we're able to actually serve people with a very open dialogue back and forth between their active substance use and whatever other needs that they have. It's a lot easier to have good conversations with clients when the clients know that they can be open and honest with you about their substance use and their needs related to that. We see a lot of individuals whose substance use is part of their lives, but it's not an overwhelming part of their life. They are not at a point where where they feel like they need services. They just need access to people who they can be frank in that discussion about. I just wanted to touch on this program as kind of a small part of the work going on in Grand Forks, but then, and we'll have time to talk a little bit more, have questions and answers about it at the end. But I did want to really segue over, since we are a little bit short on time with this presentation, I wanted to segue over into a discussion on behavioral health care during the pandemic. So I will move it over to Heidi and Rebecca to talk about the COVID Connect program and about their experiences transitioning into providing mental health services during a pandemic.
Thanks, Michael. Good morning. Michael's asked us to present on the COVID Care program, a program made possible through North Dakota's emergency grant to address substance use and mental health issues during COVID-19. The grant is funded by SAMHSA and administered through the North Dakota Department of Human Services. So I'm going to share quickly what COVID Care is all about, how it came to be, some statistics on what we've accomplished to date, and the primary services that we've offered during this pandemic. COVID Care honestly came to be as a result initially of what Heidi and I experienced in our clinical practice at the outset of the pandemic. And that is that there was just an intense and immediate surge in need for services related to anxiety, depression, isolation, and obviously a lot of loss, whether that's through death, divorce, a lot of anger and discord and beliefs and behaviors during the pandemic, and loss of social supports and whatnot. And so we just saw immediately mental health issues skyrocket. And at the same time, in stark contrast, we had talked with Michael about many of our clients that come generally to our substance use disorder treatment program simply disappeared completely off the face of this earth, it seemed to us. And so Heidi and I were discussing, man, there's an incredible need here, both for mental health, and we're wondering what's happening to these individuals with some substance use issues. And so we decided to apply for a grant to work with individuals on mental health and substance use issues, and we were awarded a grant to provide these services via telehealth throughout the entire state. So it's maybe a bit more than we initially anticipated, but we were excited to be a part of it. So COVID Care's purpose, the primary purpose is to provide telehealth treatment to those in need of mental health or substance use disorder services during the pandemic. And the secondary purpose is to provide case management services, to connect people to services, to provide supportive services, connect them with job services if they've lost a job, provide support, and hopefully within their community. But if they're unable to or don't have health insurance, then we could also provide that service via telehealth. We transitioned our practice over from 100% in-person to 100% telehealth during a very, very crazy first week of this pandemic. And so we had the capability to offer that. A third focal point is to get the word out that treatment, resources, case management, support, these things are available during the pandemic. And so outreach and an ad campaign and whatnot were an important part to limit the number of clicks people would have to go through in order to find services on any given day. So a few statistics on what is being provided and has been since October of 2020, and that is, first of all, most importantly, direct treatment. And when I say direct treatment, that's through telehealth platform. We've provided over 400 individual and group direct treatment contacts to individuals with substance use or mental health issues impacted by COVID-19 who do not have insurance. So there's been a lot of referrals of other individuals to other places for resources and for services. But specifically, we provide the telehealth for individuals who do not have insurance. Secondly, on case management, we've provided direct one-to-one case management services for approximately 100 folks so far to connect people to services or to help them if they're having difficulties with websites or other things, to connect them up with what they need. That includes a support group, individual or group support services, to 192 participants to date. Third is the outreach and the resources, make things available. And you see in front of you a couple of our COVID care flyers. That's just a couple of, I don't know, hundreds that we've put out on different topics. One is to show, the one you can see is showing resources and availability at Heartview and ShareHouse and Agassiz and Sanford and First Link and the human service centers and all the different individuals and programs on this grant. And the other focuses a bit more on uninsured. So each time we would try to reach out to feeling isolated, feeling anxious, feeling depressed, job loss. We continue to reach out, hoping that on that any given day, somebody may go ahead and take us up and link into our services if needed. We created a webpage on our website for COVID-19 resources. And since October, the COVID-19 resource page has been our most viewed page every single month. So in May alone, we had 584 visits and actual engagements using that resource page. So we can talk about that a little bit later if we want, but basically people can get in for any region of the state and look up resources that they might need. We created a Facebook page to share our resources and links to services, and made regular posts like with these types of flyers that you have in front of you. And we engaged in a social media ad campaign. And again, in May, we had 434 engagements, and that means people following up and following through with clicking into the services and requests for services or resources. So the goal is to reach all of the major cities and the rural populations across North Dakota. And so far, our numbers have come in engagements that we are hitting all age groups and cities based upon population percentage-wise. So working and moving forward on that. Moving forward for COVID care and many of the other programs, I think history gives us a picture of what happens after a significant traumatic event, disease, war. And I think we need to listen to history as it tells us that needs grow as we move through and we move into a recovery period. And I share with you just a few brief statistics from an article in the American Psychiatric Association in May of 2021, which found that 43% of adults said that this pandemic has had a serious impact on their mental health with depression or anxiety. Other symptoms reported were problems sleeping, difficulties concentrating, fighting with loved ones, fighting and abuse within relationships, drinking excessively, turning to drugs, and also gaining weight. So we have just a lot more symptoms than that, but a lot of symptoms and issues and impact from this pandemic, and all of these factors add up, right? So 43% reported symptoms of anxiety or depression. That's a significant impact moving forward. So we know North Dakota Department of Behavioral Health, the Public Health Department, North Dakota providers are all busy working, planning how to address this immense need facing us as we move forward through the COVID-19 pandemic. And Agassiz and our COVID care program is just glad to be a part of it. And we like the idea of working public and private sectors working together as we all try to address the, I think, pretty immense need that is facing us and will be facing us for some time. So that's in a nutshell, Michael.
Thank you, Dr. Green. So moving on to some of our question and answer. So I'll start out the question and answer opportunities along the way, and then we'll move to an open question and answer session. Dr. Green wanted me to share this picture as evidence of what it's like transitioning to telehealth overnight. So I wanted to make sure to include it in this presentation. But could you briefly describe the transitions and changes that you did make in your behavioral health practice because of COVID-19, both on the mental health side and on the substance use disorder programming side?
I'll start and I'll let Heidi get to more of the details and whatnot. But yes, I definitely was trying to think of, okay, what was this like? And I'm sure a lot of you have experienced this, but I think sometimes the best way to connect is through humor. And I don't know what I would have done without Heidi and humor during our transition to telehealth. We seem to enjoy sharing stress with one another, and I think this picture just totally depicted in this slide the bewilderment with the task at hand, the use of chocolate as a serotonin booster to get ourselves up to task, and basically they look a total mess. And if you could see the two of us after 1 week of no sleep and transitioning, we thoroughly enjoyed our practice session on our telehealth platform as we initially started out. So that's just a personal experience the two of us will never forget. Now I'll turn it over to you, Heidi, to talk more about the details of that.
Yeah, you're absolutely right. The transition to telehealth was chaotic, and yet not so much in that it came abruptly. We talked on, I believe, March maybe 13th or 14th, and decided to close the doors to Agassiz for in-person services on March 16th of 2020. And we transitioned to 100% telehealth over the course of the next 2 weeks. During that time, we had to pick a platform, we had to create consents for telehealth, and we had to make contact with all of our clients. We had to make sure that there was continued care through telephone contact during that time when clients were wondering what was going on and in a lot of chaos themselves. And then luckily we already had an electronic health record in place. So all of our clinicians already had laptops with cameras and speakers. So everybody gathered their things, went home, and learned how to use the HIPAA compliant version of Zoom, which we purchased, and then sent out directions to our clients also through the patient portal that we had through our electronic health record. So it was quite the event, and yet as we eased into it over time, it's become much easier to engage in. We had to hire two IT people to help with the transition, not only for our staff and clinicians, but for our clients, so that they were comfortable with the new technology. And then over time, most people now recognize what Zoom is, and they understand it, and it's a little bit different being in a HIPAA compliant version of it, but it's understood. Except for perhaps there's a few patient populations that struggle still, that mostly the elderly. And fortunately, Medicare has allowed us to have telephone or audio only telehealth for them, which has really been a godsend because they do appreciate the continued telehealth. They appreciate the treatment, and yet they're not at all comfortable, many of them, with the audiovisual. And also, some of them still just have landlines. That's what they're dealing with. So there's no potential for audiovisual connection.
So what percent of your clients are you currently seeing via telehealth?
Michael, that's a really good question and timely, because we're just transitioning back into some in-person services. So up until the end of last month, we were 100% telehealth, and I would guess that about 95% of our patient population transitioned into telehealth with us. There were a few that chose not to transition into telehealth and to wait for in-person services and or to be referred somewhere where there was in-person services. Now, approximately 75% of our organization is still using telehealth, and there's a few clinicians that are back to using in-person services, and that's going fairly well also. So it's a good transition back.
If I could add to that, Heidi, and maybe we're going to say this later, but a couple of our clinicians were planning to return to in-person services, but upon discussing this with the individuals that they're working with, they had such a high percentage that did not want to transition for a whole number of reasons we can talk about later, Michael, cost-saving reasons, that they actually decided to delay their transition back to in-person services because of the client feedback.
So kind of jumping around on my questions that I had planned, but this is a very rural focused conference. So how have you been able to better serve North Dakotans in rural areas because of the pandemic motivated practice changes such as the move to telehealth?
It's been fantastic, honestly. I really, at the very beginning, looking like Lucille Ball, it was like, I don't know how we're going to do this exactly. But as I said, as we become comfortable with it, it's really been a wonderful transition in that students that I personally have treated through like Griggs, Steele, Trail County, Upper Valley, up in Cavalier, Grafton area, have been able to go into private rooms and have their counseling sessions during the school day without leaving school, without traveling anywhere, without missing school. Usually we do it over their lunch hour or during a study hall. And they're perfectly happy doing that. And actually, it works much better with their availability and their ability to get to therapy. So that's been super. We've also been doing, we have 2 school contracts with multi-districts that are in rural North Dakota, and we've been able to provide their testing and their evaluations through telehealth. So it cuts down on travel time for us to go to the places, and cuts down on just, again, the students missing school. So that's been fantastic. And I think that the same thing happened with the adult population, is that there are people that we see who travel 2.5, 3 hours to see us, and weekly or every other week. That's missing a whole day of work to go to therapy. So they're very dedicated clients, and yet the ability to take an hour out of their day rather than 5 or 6 to go to therapy has been an enormous benefit for them financially, emotionally, and also it's just helped with people being able to make it to their appointments. There aren't nearly as many cancellations because you can call them and say, "Hey, can you jump on? You forgot." And they're like, yeah. I'll get someplace. I'll run out to the parking lot in my car. I'll be right with you. And it works much better than trying to reschedule people that for whatever reason can't make it to their appointment. And it's also just a protective factor for people who don't feel comfortable coming into in-person services at this point in time. Whether it was because it was prior to the vaccine rollout, or because of health concerns, because of other people in their family having health concerns and just wanting to make sure that they stay in COVID-free places. It's really been enormously beneficial.
So how do you see integrating telehealth into your long-term practice? Like in your ideal world, how much telehealth would you be doing? How much in-person services would you be doing? Have you had a chance to think about that?
We have thought about that, and we've thought about that a lot. And, you know, in a perfect world, I think that we want telehealth to continue. We've provided telehealth for over a year. It's shown to be effective. It's shown to be cost effective. It's shown to be beneficial for all involved. And yet we also have to keep in mind that there's other factors that are impacting our ability to provide telehealth. For instance, if insurance companies decide that reimbursement for telehealth, the way it is currently provided, is no longer available, there are going to be people that it's not going to be a benefit to have telehealth. It would be for the client. It would still maybe be a benefit for the clinician because they wouldn't have to be in the office. They could be somewhere else. But the client would have to travel to a clinic or to Agassiz to have the telehealth services. So yes, in a perfect world, if telehealth stayed the way it is, and if reimbursement stayed the way it is for telehealth, so that it's financially feasible and it's feasible for our clients also, I'm sure that our practice is going to remain at least partially telehealth.
And focusing more specifically on, I don't know if we clarified this at the beginning, but Agassiz Associates runs, a kind of a full spectrum of behavioral health services. They provide medication services for mental health related needs. They provide mental health counseling, and they also provide addiction counseling. How has that worked with providing addiction counseling specifically? We've talked a lot in the pandemic about how addiction concerns have been very top of mind in addition to mental health concerns. So how has that worked providing addiction care during the pandemic?
Yeah, that's a really good question, Michael, and it's worked very well, honestly. We provide both individual sessions for individuals seeking addiction or treatment for addictions, and also we provide group sessions, and you can do that very easily on Zoom with the platform that we have. So people are just in their own space and they join the group session, and they have group sessions together but apart, and it's worked marvelously well. The one very unfortunate consequence of the pandemic was on our addiction treatment in Grand Forks County Correctional Facility, that we were providing services, in-person services, group treatment there prior to the pandemic. But when the pandemic came along, those services were no longer able to be provided because of the quarantine and the things that had to happen at the county. However, we'd like to try and work in the future to get that going again and to revive that service. One of the issues that we are going to run into is that many of those individuals received treatment through the SUD voucher, and unfortunately now the SUD voucher does not pay for telehealth group sessions. They only pay for telehealth individual sessions. And so that's going to be a difficult thing to overcome if you were to provide telehealth sessions for people with high level of care in addiction.
And then we've touched a little bit on the payer issues and the client adherence. What has been what have been kind of the highlights of this kind of sudden practice change? So, if you could kind of sum it up into a few words, how has this changed the way that you serve North Dakotans and the communities that you serve?
At first, because it was so overwhelming, I was wondering personally if we could provide the type of high quality care that we pride ourselves on providing. I mean, Agassi Associates, above all else, wants to provide high quality care for the clients. That's just essential. And so we don't want to take on more clients than we can. We want to provide as much service to North Dakota as possible, but at the same time not compromise quality. And so learning how to engage people over a telehealth platform was essential. But now that I would dare say almost mastered that, it's really opened up the doors to the idea that we can provide services to people in many different areas throughout North Dakota. And with the COVID Care Grant, that's also allowing that to happen. And it's kind of like a silver lining in this huge, huge cloud that's been following us around for over a year called COVID. And I don't know that we would have moved telehealth like this had the pandemic not happened. And yet we're here now, and it's actually been a really eye-opening and encouraging event in that way.
I would say too, there's some folks obviously in rural areas that we can now reach that they would have a hard time getting in. And I think we've seen more, it's North Dakota. So professionals who have a safe way to engage in telehealth without going somewhere locally or whatnot, they can do this via telehealth, and it just seems to have spurred more people reaching out in that way, especially for North Dakota.
And so my final question, so if you're, we have some representation from rural provider organizations or rural public health units. If you're a rural provider and you're interested in engaging with, with providers or referring clients, would you guys have any tips for how your services could be useful in a for a rural provider looking for some sort of solution for providing mental health care for their clients?
Yeah, right now the way that some providers are even doing that is just when their patient is in the room with them, they call to Agassi and get if the patient doesn't have insurance. Find the COVID care case manager, they get back to them, within that day, and we make the appropriate referrals and or take care of the treatment needs ourselves. Also, just connecting up with us. I think that we've found throughout our numerous years of practice that the best thing to do is to just make contact with people and to recognize that we're here to serve North Dakota, and that we want to work together as a team to provide those needs for North Dakotans to take care of them. And so if somebody in a rural clinic has an idea about how to expand services or about have needs that aren't being met that they would like to talk to us about, Rebecca and I are doing our best to have administrative time to do that, and would be happy to talk with people about that and make plans together and try and assure that rural North Dakota is taken care of just as well as what we might call urban North Dakota. So making those contacts, feel free to reach out to either of us or both of us, and develop those personal professional relationships. It's essential, and that's what we've done in our business. That's our business model, is that every single employee that we have a professional relationship with, that's on a personal level also, that we care about not only the state of North Dakota and its population, but our providers and our clients.
And I think that's the, thank you so much for the wonderful input. I do want to, give a little bit of a chance, since we got started a little bit late. I think we can probably go for at least another 5 or 6 minutes. I wanted to give everyone a chance to ask questions of either myself or of Dr. Jensen or Dr. Green regarding the opportunities and changes within the behavioral health care kind of infrastructure in Grand Forks, or providing how we can provide services more efficiently because of the availability of telehealth, anything like that. I see we still have about 55 people on, so we are very open to your questions.
Michael, thank you for your guided questions to our additional presenters today, Dr. Jensen and Dr. Green. Just a reminder, you can post questions in the chat or the Q&A, and I'll monitor that. I did post a question for you, Michael, which you can take now or you can take later. It's not related to telehealth, but related to behavioral health services. It's in the Q&A section, and I would just encourage people, even if you have discussion or observations, to feel free to put your remarks in the chat.
And I see Debbie's question. Could you comment on how you maintained services for clients in the SSP during the pandemic, and also how clients could still get medication-assisted treatment for opioid use disorder? So focusing on the first part, how we maintain services for clients, as I kind of lightly touched in my beginning section, we moved our syringe service program to a completely mobile basis, essentially overnight, just like everyone else. Everything changed overnight. So what we ended up doing for reaching clients was we actually established a Google Voice number that would forward text messages on that number to the staff of the syringe service program. From there, we could text back and forth with the client, arrange a mutual location that was relatively public. So generally, we didn't get out of our cars, but we would meet a client in a spot that would work well for them, and we would provide those services. We would collect supplies. We'd provide them new supplies, and then we would do a brief discussion with the client, and then we could provide additional services by phone. That's one of the things that we've been able to keep as we've kind of moved back into a fixed location, is we've been able to keep both our phone number, so clients can call and ask us questions. They can text us with questions, and then we can also do some limited mobile services related to providing used injecting equipment pickup. So making it easier for clients who are worried about prosecution if they have used injecting equipment on them, so we can pick it up. And then for clients in the syringe service program, we also will provide Narcan on a mobile basis to them if they have a need for that. But we no longer operate the syringe service program on a mobile basis. And then moving to how clients could still get medication-assisted treatment for opioid use disorder. Fortunately, that was one of those changes that happened with the pandemic, was that telehealth and telephonic care became available for medication-assisted treatment, in addition to all the other areas. And so Spectre Health was able to keep most of their clients still engaged in care through telehealth throughout most of the pandemic, and were able to keep kind of similar client levels based off of my communications with them. So they were able to do telehealth for care, and then occasional in-person client visits. So The other provider organizations that we've also coordinated with, like Ideal Option, which is in 5 North Dakota locations, they were also able to transition to telehealth for much of their care as well. Any other questions for either Doctors Jensen and Green or myself, who's not a doctor?
If anyone else among the participants has any success stories to share that you'd like to add to the chat, feel free to do that. The success stories in the behavioral health world to me are just something that's been very, very encouraging. During this difficult time of COVID, we all had to improvise, and you all are shining examples of how to improvise and how to do things rapidly.
I see one more question in the question and answer section. Does Agassi Associates provide services in local county jails?
We had the pilot program in Grand Forks County, in the Grand Forks County Correctional Center, and have not been able to extend to other county jails since the inception of that. It just got going and was really going well prior to the pandemic hitting, and then everything came to a screeching halt. So it's not something that we aren't considering, and we have reached out to some various different people that could help with that situation, but it's right now, again, because of the SUD voucher situation and the telehealth not allowing the group sessions to be billed that way, it would be very difficult to have the level of care necessary through telehealth for people seeking services. So it's not that we're opposed at all, it's just that we are trying to juggle many things in the air right now, and that was one of the things that got set down as the pandemic came.
Heidi, I'll follow up with a question to that. Are there some things that we could do in the policy arena to change that would be beneficial for the program as well as the people who depend on that voucher program? Or is that something that's going to take a whole nother legislative session to change the systems?
You know, I'm not sure about that, Debbie, and it's a really good question, because if there was something that could happen, it would be to reinstate the payment for telehealth group sessions through the SUD voucher. I don't understand the difference between the independent or the individual sessions being reimbursed and the telehealth for group sessions not being reimbursed, because it's essentially the same service, just with more people involved. And so I wonder if people didn't really understand exactly how group telehealth was done. I don't know. I really honestly wonder that. And so in order to move forward too, I think that we were hoping to be able to start, and we were starting to gather success stories from the people that had received treatment in the correctional facility that were coming back out of the correctional facility, rejoining the community, and having great success in doing that, staying clean and sober, making good decisions in their lives, and moving forward in society. And that was just really heartwarming to see. It was fantastic. And so we'd love to get back in there and continue those services so that people can lead healthy, content, happy lives as they rejoin society after they're done in the correctional facility. You know?
I think it does a couple things too there, right? Already have the connection coming when they're released.
Absolutely.
And so that connection is right there, and those supports are right there. And two, the voucher is a temporary thing. The work moves forward to getting people on health insurance and getting people employed and working together with other agencies or whatever. So it's a temporary stepping stone that is just needed to provide that. There's not too many choices otherwise when you're in a correctional facility or jail. So it's temporary.
And could you see a potential policy option, also extending for mental health services in correctional centers using a similar framework as the SUD voucher.
I think that is a fantastic option. And yes, we've been talking about that and hoping for that. And if that was possible, we would, certainly be signing up for it. I think that would provide very similar service and help people enormously, not only while they're incarcerated, but like I said, after they are back into society, they have that connection, they have that support, they have the treatment that they need for their mental health, and not just medication. I mean, we know that medical treatment through the use of medication management is helpful, but we also know that for long-term care to be successful, that we need a combination of treatment that's both therapy and medication management. And so to be able to get that therapy part available to those individuals, that would be an awesome move forward. Yeah.
And the connect to financial supports and peer supports and other services and whatnot, to build that as people, again, are no longer incarcerated. That'd be a wonderful opportunity.
We have just 5 minutes left or I guess actually 4 minutes left in our time together. And I did want to offer my thanks. I don't want this to shut off on us without thanking our presenters today. We can stay in for another minute or two if there's more questions. But I want to thank Dr. Green, Dr. Jensen, Michael for sharing information with us about opioid and behavioral health success stories in the Grand Forks community. I just want to thank you so much for all that you've done to share your time with us today, to share success stories. And I'm a firm believer in relationships. I think we do all this work because of the relationships, not only with clients, but with each other. And we've built a strong network of behavioral health provider relationships in the Grand Forks area. And I think it's strengthening across the state as well. And I think we're making a lot of progress. So I thank you all for sharing your stories about how to overcome some of the challenges in the COVID arena, COVID time that we've all endured the last 16 months or so. So it looks like we're going to be cut off in our presentation, but thank you everyone for attending the Dakota Conference on Rural and Public Health as well.